obviously we're always looking for other therapies in our relapsed CLL patients. And certainly, it would be neglectful not to mention CAR T-cell therapy and, of course, allogeneic stem cell transplantation. Of course, I think allogeneic stem cell transplantation has also decreased in our CLL population remarkably over the years, just because of the advent of the novel agents. Those were typically the patients that had high-risk disease, 17p, p53, complex karyotypes, had failed chemoimmunotherapy or other therapies, or may have transformed. And so, we would be taking those young, fit, high-risk patients to transplantation, but they were still a minority of patients that we were seeing. And so now we have CAR T-cell therapy, and clearly we've made a lot of strides in CAR T-cell therapy not only you see improvements in the response and efficacy, but a decrease in the side effect profile of CAR T-cell therapy. And so clearly it's a modality that's being more clinical trials. It's obviously approved in our relapsed diffuse large cell patients and as well as ALL. But certainly ongoing clinical trials in CLL look very, very promising. Now, of course, whether we use that modality after many subsequent lines of therapy, this is always an argument, right? So if you save things like transplant and CAR T-cell until the patient is really refractory, those are harder patients to salvage with these types of modalities. And so, clearly, depending upon how that data goes, if the efficacy and the side effect profile continue to improve, clearly, there's a potential that those modalities, or I should say CAR T-cell, might move up. But right now, it typically tends to be patients who are multiply relapsed, where we're still using CAR T-cell, and then again, transplant seems to be further pushed down the line, given these the plethora of combinations and these novel agents that are approaching. And as I said, now that there's many either second generation and other BTK inhibitors that we're evaluating to salvage our patients, these modalities tend to be pushed off further. And so we're going to have to, and certainly we're looking at other B-cell receptor pathway agents that are being studied. And there's lots of new novel agents in the B-cell receptor pathway that obviously we're looking at as well. PKC, I mean, there's a ton of new agents, CDK9 inhibitors, there's a ton of new agents that are in phase 1, phase 2 trials that are constantly also being evaluated for CLL and refractory CLL patients. So I think that certainly in terms of groundbreaking transformation of CLL therapies, the BTK inhibitors, venetoclax-based treatments, these really have changed how we approach our CLL patients. They've improved the overall survival and the progression-free survival of our patients. They've been dramatic improvements to the therapy of our patients. And so I think these are going to be the mainstays of our treatments. Now, how mono versus combination and all these things are still being worked out, but they're clearly, these are drugs that are here to stay. And then hopefully we'll find newer therapies as well to salvage even those players who have relapsed after BTKIs or after venetoclax-based combinations, because we'll always be looking for newer therapies, hopefully curative. Hopefully one of these will be a curative therapy for all. But given that the disease is so complex and there are really probably, right, it's not really one disease, that there are multiple subtypes, that it may not be necessarily one agent by itself, but it might be a combination of agents that will achieve such a cure, or certainly a long disease-free survival, as did in that subgroup of those 13q mutated patients, who some of them have gone over 20 years without needing therapy. That would be the best thing that we could do for all our patients with CLL. So I think stay tuned. Lots of clinical trials, lots of exciting things, but we still have a lot to learn from the agents that are even approved. And we still have, if we can decrease the side effects of those agents for our patients, so nobody has a problem, that would be best for all. So stay tuned.